So I'm Robert Hamble. I'm a heart failure clinician up at the University of Vermont Medical Center up in Burlington. Thank you for the opportunity to come here today and talk to you about heart failure. I've been doing heart failure teaching at the hospital for about 2.5 years, 3 years now. And when I started off with the project, my job was to create a program to educate nurses on how to improve patient understanding of heart failure, with the ultimate goal of reducing readmission rates. And so we created a program that mirrored national standards of education, and today my goal is to just kind of give you some tidbits of what we teach the nurses in Burlington on how to educate. We understand that the world we live in today is we don't have time to sit down and speak to a patient for an hour at a time. But we do have time throughout the day while we do med pass, while we do assessments, to sprinkle in information. So I want to give you guys some tidbits about what those things you can pass along, how you can push the envelope while it isn't necessarily overwhelming your day. Okay? Whoops. Perfect. So I want to start off with this really cool concept. And I use this to do teaching with all patients at our hospital. Basically, our population are, how are you?
Hi there.
Our population are people elderly, 65, 75, 85, 95. And this really relates to them. I've grown up, I remember watching I Love Lucy with my mom. All of our patients remember this. So I'm going to let this play, and then we're going to talk a little bit about this. And this is really going to correlate right back to everything we talk about with heart failure. So that kind of correlates right back to what heart failure is all about. You know, the heart is Lucy, and the chocolate's the fluid in the body. Now, if we can control the amount of fluid someone drinks, the amount of salt somebody eats, that conveyor belt goes really slow. And the patients understand that. Okay, if I watch that out, the conveyor belt goes slow. Am I pumping Lucy? Well, she can keep up. If we're at home eating the hot dogs, the cottage cheese, the soups, well, that's when that conveyor belt starts to speed up. And when that speeds up, when the conveyor belt speeds up, well, Lucy can't keep up. And when your heart can't keep up, the same thing happens. But unfortunately, Lucy gets to enjoy chocolate. As you as a patient, your lungs fill up with fluid, your legs fill up with fluid, now we're in trouble. And that's kind of the concept we talk about with the patients. So they try and relay it back to them, give them simple things. Often on our floors, you'll see patients when they talk to us start doing their arm movements to try and explain what's going on with the squeezing of their heart. Now, I'm a cardiology nurse. I'd like to find out what everyone else does here. So Kathleen, where do you work?
I work in cardiology.
Awesome, cool.
I
All right.
work in the stress testing department.
Stress testing, perfect.
Hi, Justine, Infusion Center.
Infusion center.
Donna, education and ED.
Okay, cool.
Jennifer, I work in cardiology as an office nurse.
Awesome, great.
Med-surg.
Med-surg, perfect.
Geriatrics.
Okay, great, awesome.
I'm Lexi, I'm new to the med-surg unit.
Sweet, great, all right, cool. So today we're going to spend a little time, I did research for about a year about heart failure, and what we found out is that we as nurses don't do teaching when we don't feel comfortable about what we're teaching about. So I want to provide a little bit insight about systolic heart failure, diastolic heart failure, to boost your confidence about how to educate. Because if we feel comfortable in educating it, then when you get on the floor, it's a lot easier to intermingle into your day. And then we're going to talk about some things about foods, what we call the core four. Now, I'm not sure if you guys have seen this. This is what you guys use here to do heart failure teaching with patients. And it's an awesome packet, okay? There's a lot of great stuff in it. You have this awesome logbook, and we're going to talk a lot about that today. And we're going to talk about what it's for. Then you guys have a great booklet about understanding heart failure. Really, what I would say is soup to nuts, the whole entire thing. And it's really great. And the perfect about it is what you're going to teach is all of this, but when they go home and forget everything, it's all in here. All right, cool. Perfect. So here are the nitty-gritties about the numbers. We are going to see more heart failure patients. Right now, 5 million Americans have heart failure, but by 2030, over 8 million Americans will have heart failure. That means 1 in every 33 people. Now, 26% of our population will be over 80. Heart failure prevalence increases for people over age 65, and seeing that I just turned 40 on Saturday, I'm a little worried about that. 1 in 5 Americans will develop heart failure. Now, all of us here today, are we predetermined to have heart failure?
Genetics.
Genetics, but heart failure is a secondary disease. So none of us here are predetermined to have heart failure. But to your point, some of us are predetermined to have high blood pressure. Some of us are predetermined, like me, to have high cholesterol. And those things can cause incidents like a heart attack, which then causes heart failure. So it's really important because a lot of times family members come in and say, my dad has heart failure. Does that mean I'm going to have heart failure? And that's not true. What we want to tell people is if you manage your comorbidities, diabetes, hypertension, high cholesterol, you should never have heart failure. Okay? So we'll do a quick patho because it's 7:30 in the morning, so who doesn't want to do a little patho at 7:30 in the morning? Just like school and nursing school when they meet a 7 a.m. class. I don't know why. But this is your heart, and this is the cycle for it. You know, blood in blue returns back into the top right atrium, goes down to the right ventricle. Blood then gets pushed into the lungs. It gets to being really happy. It turns from blue to red, goes into the left atrium, into the left ventricle, and then it's shot out into the body. So, now, heart failure is really interesting because there is left-sided heart failure, there's right-sided heart failure, there's systolic heart failure, there's diastolic heart failure. So there's a lot of varieties, so when people say they have heart failure, it can be many things for it. All right? I promise I will try and not make this too much school, but this is really the core foundation about heart failure. It's all about cardiac output. And what makes up cardiac output?
Stroke volume and, oh my goodness.
Yay, fresh nerves.
Stroke volume and, heart rate?
Perfect.
Yeah.
Exactly.
Good
Thank
job,
you, Lexi.
Lexi. Good job.
You get a star. All right? You get some salt packets in the end. All right? So that's it. And this is really all about heart failure. Because at the end of the day, our heart's job is to manage our cardiac output. So if we are running Well, our body says, okay, I gotta increase my heart rate or my stroke volume because of my cardiac output. And the problem is when you have heart failure, your cardiac output gets decreased. So one of two things happens. Your heart starts to race faster to make up for it, or your heart tries to squeeze harder. And those all sound like really awesome things. But in the end, that's the demise of heart failure. The heart's job of trying to compensate for the heart is what actually hurts the heart in the long run. All right? So, what's systolic heart failure? Lexi?
The atria. I don't know. The atria of the heart can't is systolic. The atria of the heart can't pump effectively, so you have backflow.
Yeah, well, systolic heart failure deals with the heart not squeezing as well as it should. So oftentimes, the atrium can affect it, but mostly it focuses on the left ventricle or a ventricle. But to your point, it can be any part of the heart that isn't squeezing as well. So people who walk by M5 will see patients look like they're working out because a lot of times when we talk to patients, we use our arm. So with systolic heart failure, when we educate, we say, you know, a normal heart squeezes like this. When you have systolic heart failure, your heart kind of squeezes like this. It doesn't push as well as it should. And it's kind of funny when you have an 85-year-old lady going like this. But it's amazing because you're like, all right, she understands the concept. So to your point, systolic heart failure is the ability for the heart to not squeeze as well as it should. All right? The heart can't pump with enough force, weak muscle, your ejection fraction is severely reduced. Now, this systolic heart failure often happens, due to MIs. So, part of your heart, there's a blockage in it, the part of the heart doesn't get blood, the muscle goes to sleep or dies, and your squeeze functionality gets worse. Okay? Now, I paid a lot of money for these pictures, so I want to show them to you, okay? So this is a normal heart. Notice how the muscle's a little thick, but that's normal, because the left ventricle, its job is to squeeze the blood out of your heart into your body. So it's got to be the strongest muscle there, okay? So that is okay. But in systolic heart failure, this muscle, for some reason, gets weaker or dies, and this chamber becomes much bigger, and unfortunately, the ability for the heart to squeeze becomes less. Causes of heart failure. Well, one is a heart attack. What are some other reasons why heart failure?
Valve disease.
Valve disease, yeah, for sure.
Fluid buildup.
Fluid buildup is definitely a sign of heart failure, but it's actually the byproduct of heart failure. Yeah?
A large, boggy heart from hypertrophic, or, yeah.
You know, things like hypertension, drug abuse, diabetes, those are all things. So, think about a heart. Now, a heart's like a water bottle, okay? We fill it up with water, and it squeezes, okay? So this is my heart, and this is my muscle, okay? And in a normal heart, we squeeze, and water pours right out of it, okay? No problem. Now think about that. There's a full squeeze, water shoots out. That's a normal heart. But when you have systolic heart failure, you still got that chamber of fluid just like this, but instead of having a really big fist, you just got 2 fingers. And now, when you squeeze, you just don't get that force. And that's really what systolic heart failure is all about. You just don't have that force to squeeze the blood forward. So to your point, fluid starts to back up into the body. All right? Let's see how well we did. Cardiomyopathy, reduced blood supply, coronary artery disease. All right. Valve diseases, someone said. Arrhythmias, AFib is another big one. The heart, the top part of the heart's just quivering, it's not squeezing. The heart has to work harder. When it can't work harder, muscle starts to die. Perfect. Now, all honesty, for 7:30 in the morning, you guys are doing pretty good. All right? Ejection fraction. We always hear this. We look at echoes. What are the first thing we look for? What's the ejection fraction? And for us, it's a really important number because it's the amount of blood pumped out of the ventricle versus the total amount of blood in the ventricle. Now, when you walk into a room and tell somebody they have an EF of 60%, we're really happy because that's normal, but everybody else freaks out because we come from a world of math. And we all want A's. We're all nurses. We're overdriven. We want A's in nurse classes. So we're always thinking we want to be 100%. But really, in truth, 60% is knocking it out of the park. And that's really a good concept to tell patients is, before you tell them the number, tell them that it's not going to be 100%. All right? Speaking of, a normal ejection fraction is anywhere from 50 to 70. If you did an average of most human beings, most of us squeeze between 60 and 65%. Okay? Abnormal is 40 to 50, which means you're not necessarily classified with heart failure, but we treat you like you have heart failure. And anything less than 40, well, that means you have heart failure. Does heart failure go away?
You can improve it by improving muscle tone.
Yeah. But does it, a lot of patients say, well, I had heart failure, but then I left the hospital and it went away.
It's like who takes blood pressure with
Right.
beta blockers. I don't have it anymore.
Exactly. So we always really emphasize that you will always have heart failure. When you come to my hospital and you're fluid overload, you have congestive heart failure. But they need to understand that because they still need to manage it. This is like diabetes, where it's something they have to manage for the rest of their life. Alright, so why does systolic heart failure cause the demise? So, systolic heart failure, as you said, Lexi, is pumping ability is down. So if your pumping ability is down, what happens to your cardiac output? It decreases. So I'm running, but my heart's not working well, so my heart says, well, your cardiac output, I got to do something more. So either it's going to increase my stroke volume or increase my heart rate, which increases my work. When I work harder, my demand for oxygen becomes greater. Now the problem here is your oxygen goes up, but you have a weak muscle. So your muscle can't keep up, and now unfortunately, cells die. And over time, someone whose EF was 35 5 years ago, if they're not managing it correctly, now it's 20, 25. And now we have to put a pacemaker in them, and now we have bigger issues. Okay? Perfect. So there's systolic heart failure. We have diastolic heart failure. Now I kind of gave you the answer, but talk to me about what diastolic heart failure is. Go for it, Lexi. Everybody owes Lexi a coffee. All right?
Your heart can't relax, so the blood can't fill back up
Yeah.
in time.
All right, so take a look at this. So when it comes to hearts, so remember a normal heart, this thing fills up with water, you've got a great squeeze. Now with diastolic heart failure, we're always really stoked because we look at the echo and it's like, wow, this person has an EF of 65%, we're great, there's no heart, oh, hold on, mild LVH, or medium LVH, or severe LVH. And oftentimes we just kind of disregard that, and we're just so focused on that echo of the EF. But that mild, moderate, severe LVH is all about the muscle growth. So think about that. When your muscle grows, I always say to the patients, your heart is working harder than it needs to. It's kind of like when I go to the gym, I try and build muscle. Now for me, building muscles in the arms is a good thing, all right? But for the heart it isn't. Because when the heart builds muscle, well, unfortunately it gets stiffer. I always think about when I go grocery shopping and I walk down the magazine aisles and I see those muscle magazines with those guys with the huge muscles, and they can't really walk because their arms are so big, right? And that's what happens with your heart. When the muscle gets bigger, it becomes so much more stiffer. So back to that arm thing. A normal heart opens all the way up and it squeezes, opens all the way up and squeezes. But when diastolic heart failure happens, when that muscle gets bigger, the heart can only open up like this. So instead of getting a full cup of blood, the heart may only get half a cup of blood. Now you're stoked because they have an EF of 60%, but the problem is they're only squeezing 60% of a half a cup versus a full cup. So their overall output is much less. All right? Back to the water bottle syndrome. So in diastolic heart failure, you've got that sweet squeeze, okay? So just like in the beginning, your heart's squeezing just fine. But instead of having a beautiful filled up water bottle, now I'm going to get a half a bottle because that's all the room I have, all right? And now when I squeeze, I still don't get a lot out because of that, because there's not a lot of fluid in there. Let me think about another. So in a normal heart, it's like a balloon, okay? When I work out in a normal heart, my heart says, okay, I got to work harder. I'm going to stretch to get more fluid to increase my volume. I'm working out more. My heart is flexible enough to accommodate that, all right? Now, with diastolic heart failure, it's kind of like you have a cup. A nice, rigid cup. And I have a certain amount of volume I can put in there. Now, I'm working out, and I'm doing the things I need to do, but I have diastolic heart failure, okay? And what happens is I can fill up my heart to a certain point, but it loses that ability to flex. And I can't put anything more in there, and it just pours over. So in diastolic, the heart becomes rigid, and it can't accommodate for the things you need. All right? Now, why do we get diastolic heart failure? What are some of the reasons?
Atherosclerosis? Does that have anything to do with it?
That would be more for, it can, more of a systolic aspect of it, but one would be hypertension. Okay? So think about it. In a normal heart, our arteries look like this, nice and big, really easy to push blood through, okay? Our heart doesn't have to work harder. But when you have hypertension, you go from this to this little tiny straw. And now your heart's got to still push all that volume through that little straw. So to do so, it builds more muscle. Okay? Pulmonary issues, where you have lung issues, where your heart's working against your lung. Now, another one can be due to valve issues. Now, think about that. You have a heart, and your job for the heart is to squeeze blood out into the body. But when you have a valve issue, it goes in two places, right? Okay? Now, the problem with that is some of the blood isn't making it out to the heart. It goes back up. So now you're not getting that cardiac output. And that's the issue with valve issues, because you're squeezing just fine, but now going in two places, reducing your cardiac output. So those are all reasons. Now, what's the difference between a STEMI and a non-STEMI?
ST elevation?
Perfect. Now, not to say I want you guys to have a heart attack, but if you were to have a heart attack, which one would you want? Non-STEMI, right? Not as much damage to the heart, things are better. Now, if you wanted, not to say I want you to have heart failure either, you would want a systolic heart failure over diastolic heart failure. There are so many great medications out there right now, some new ones that have come onto the market that really can show that that muscle can get stronger, like you said. We can get that EF from 35 to 45 to 55. And there's hope there. When it comes to diastolic heart failure, once that muscle's grown, it's really hard to get that muscle to go away. The only way we can manage it is hopefully before it doesn't get worse. And that's by managing the blood pressures, managing the fluid, managing the salt. All right, so not as great of a story. Perfect. Once again, normal heart, muscles, thick, and that's normal. But in diastolic heart failure, this muscle becomes so much bigger that this space becomes so much smaller. We kind of talked about this. So, once again, blood supplies less, muscle has to work harder. To get that out, it requires more oxygen. When it requires more oxygen, more cells die, it becomes different. All right. What are some risk factors for heart failure? Hypertension, awesome.
Diabetes.
Obesity, love it.
Diabetes.
Diabetes,
Smoking.
smoking. You guys are doing awesome. Perfect.
Could
Those-
be congenital also. Well,
Yes.
related to.
Like you could be born with a heart defect that could then lead to heart failure. Exactly, yeah. Age, male, hypertension, MI, valve disease, obesity, excessive alcohol consumption. Now, this is a really good conversation, and this is too. Unfortunately, in the world we live in, we have, a heroin issue. And we also have people who drink excessive amount of alcohol. So for a patient who is 32 years of age, who comes into your hospital and now has an EF of 20%, it's a really realistic conversation to say, well, what is your lifestyle all about? What do you drink? What do you do? Because those are things that can cause heart failure. All right? Also, chemo treatments. It's a really interesting one, and it's something that their expectations are set that due to chemo can cause heart failure. I haven't met a patient yet that says that didn't factor. They said, I'll take the risk for it, but it is something that can happen. All right, assessment, chest x-ray, EKG, the echo, BNP, or pro-BNP. The scary thing is a normal BNP is less than 400. Now, what does BNP stand for?
By natural peptide or.
That must be a nurse educator right
Yeah.
there. But what does it mean? When we pull a BNP, what does that say about your body? What's going on?
Muscle death.
Right, or it's kicking in.
Or like muscle
Stretch.
stretch, yeah.
You know, troponins are muscle injury.
Okay.
A BNP is the ability of your heart is being stretched or overloaded. Now, assuming all of us don't have heart failure, our number is less than 100. We get worried if it's greater than 400 for a heart failure, and I bet you've all seen patients where their BNP is 12,000, 15,000, 20,000. So think about that. That's the heart being overloaded and being stretched. I had a patient explain to me, he's like, oh, it's like when I eat salty food and my jeans stretch. I said, well, yeah, kind of it is. But so just something to keep in mind when you see a patient and their number is 20,000, they're really fluid overloaded. Excuse me. All right, left and right heart failure. What's the difference? Lexi? I have left-sided heart failure. Where are the symptoms I receive?
Left, can I start with right? Right-sided heart failure is jugular vein distension.
Yes.
And pulmonary edema.
Why is that true?
Because with right-sided heart failure, the right atrium is where the blood's coming from the lungs. So if it's backing up, then it's backing up in your pulmonary system.
That's left. So it doesn't back up into the pulmonary, it backs up into the body. You said it right with the JVD. You were totally on. So that's great.
So right, you'd see it in your peripherals.
Yes.
And left ventricular failure. Am I right in saying that one's pulmonary?
Exactly.
Left is pulmonary. Okay.
I always say left is lungs,
Left is lungs,
right is
that's
the rest of the
right.
body,
Right.
okay? So to you nailed it out of the park. Left side means that for some reason this part of your heart isn't working well. So think about the Lucy thing. When she couldn't keep up, it backed up. So if it's on the left side, where does it back up into? Well, the fluid comes from the lungs, so it backs up into the lungs. That's where you get crackly lungs, can't breathe, flash pulmonary edema. Now to your part, the right side, when it can't keep up because it's not working well, what feeds into the heart? The rest of the body. And that's why you see the JVD, that's why you see swelling of the legs, liver issues. Now, a very funny story to me, but probably not to the patient, was we were talking and this gentleman had gained 45 pounds. We took off 45 pounds before he left us. We were in the room with his girlfriend and I said, do you see this? She goes, yeah. He goes, yeah, when we were at home, it was flickering here. And I just thought my husband had a very strong heart. But that was actually his JVD in his face.
Wow.
When we took the 40 pounds off, it all went away. So it's just an important thing to look at. From a nurse's standpoint, it's a really good way to assess how well we are in getting the fluid off of the patient. All right. As you said, left is pulmonary. This is like straight nursing school. Bringing back flashbacks. There you go. All right. Right is that? Perfect. That is a JVD. Thank you. All right. So, I'm going to show you a video right now, and this is kind of the basis of what we do here as a nurse, okay? And then I'm going to kind of correlate it back to why we do what we do at Heart Failure, all right? Now this guy is Michael Jr. And actually this is kind of the foundation. I watched this video 4 years ago, and it's been the foundation of what I do here at the hospital. And it's kind of what we educate nurses at the hospital to be the foundation on why they're doing what they do, all right?
know. And a lot of times when people hear the phrase, how do I know, the next thing they say is what? How do I know what? But the key really isn't to know what, the key is to know why. Because when you know your why, you have options on what your what can be. For instance, my why is to inspire people to walk in purpose. My what